Hello, everyone. Good evening. I'm Jeanette Zucker, Executive Director of the National Lymphedema Network, and it's my pleasure to welcome you all to our webinar today. It's Lipedema Diagnosis, identification and intervention. And we're very honored to have LNR USA sponsor this session. And LNR USA is a significant sponsor and they support us in many ways. And so we thank them for this opportunity. We're going to read our disclaimer at the end. And right now, what I'd like to do is welcome both Lindsay Ryback, who is I always want to make sure that the title is correct. She is the Senior Product Manager of Compression of LNR USA, and also Deana Benjamin, who, of course, is our main speaker for the night. And so, Lindsay, would you like to just tell everybody a little bit about LNR USA?
Absolutely. Good evening, everybody. Thank you for being here. LNR USA is a global manufacturer and supplier of bandaging, wound care products, and self-care garments and wraps with the Solaris collection. So we are really thankful for the NLN for hosting this webinar, and really pleased to have partnered with Deana Benjamin on the hard work that she did to put together this for this evening. We've had the pleasure to meet her at her Everything Lymphedema and Lipedema conference in New Mexico. And we are also very pleased to have worked with her as a key opinion leader for our Innovation Forum for New Products.
Thank you so much, Lindsay. And with that, Deana, we would like to welcome you onto the stage.
Hi, thank you, Jeanette.
Thank you so much.
Thank you, Lindsay. I appreciate it. Well, I'm really excited to be here. Thank you all for joining. I'll give you a little bit of background on myself before we really get started with the presentation. I am a clinical manager here in Santa Fe, New Mexico for Christa St. Vincent Sports Medicine, and also the founder and CEO and president of Everything Lymphedema and Lipedema New Mexico, a nonprofit started just a few years ago with the help of some others here, and we have held a couple big conferences in town, which has been great. Lipedema is certainly a passion of mine. Not only do I want to just bring awareness, but early diagnosis and, of course, treatment, effective treatment. After the last conference that I put on, I had to really think about how can I make the biggest impact. Certainly mentoring other therapists is a great way to help, but really if I can teach a more broad spectrum of therapists what I've learned, hopefully we can have a bigger effect and a lot more help to a lot more people. My education is, I have a Master's of Science in Physical Therapy from the University of South Dakota, bachelor's in chemistry and psychology, and I was certified through the Academy of Lymphatic Studies. Not until 2010, I had been treating for a number of years prior to that, and was blessed to have a wonderful mentor at the Nebraska Medical Center in Omaha, Nebraska. And that's how I really started treating lipedema. And I think as a lot of therapists, when we first started, we're trying to figure out how is this different than lymphedema? How is this different from obesity or adipose tissue? And how do we successfully treat this without a lot of training? Well, thank you again for coming, and we will get started here. I'm going to go ahead and start presentation. So let's see, we're going to start here with some learning objectives for the day. And there we go. So this part one is mostly about identification. So we're gonna look, of course, at the types of lipedema, as well as the stages of those types, and really go through a lot of the features that are seen in the clinic, both those that are common in the literature and some that we see more on a clinical level. We will spend a little time also on differential diagnosis, looking at the difference between lipedema and obesity, as well as lymphedema, vascular issues like chronic venous insufficiency, systemic swelling, whether it be renal failure or congestive heart failure, acute deep venous thrombosis or blood clots, arterial edema, as well as malignant edema and dependent edema. I also want to take just a minute to look at where our referrals come from and referrals that we might need to recommend to our patients. So just some general definitions of lipedema that I thought were very helpful to just start out our conversation for those that know very little about the condition. Lipedema is a disease of the loose connective tissue. It causes fibrosis in the adipose tissue, mostly in the lower abdomen, hips, buttocks, and limbs. This is normally of females. It does spare the trunk, the hands, and the feet, as well as the head and neck. A hallmark of lymphedema is the inflammation that results in the fibrosis of the tissue and therefore pain. It remains under-recognized largely because it's assumed to be just a normal hereditary component of female fat. It can be treated though. We can reduce the pain and the edema to help maintain mobility and improve that quality of life. This will help slow down the progression of the disease. And therefore we really want to make sure that as many people are getting diagnosed early as possible. Okay, so these are the types of lipedema. I think things are getting more standardized now. This is the type system that I've seen most often, and this is the typing used in the recent paper, The Standard of Care for Lipedema in North America. When I first started treating almost 2 decades ago, there was some variation in both the types and the phase or the stages. For tonight and for Thursday, part 2, we're going to stick to this typing system. So type 1 is really just the buttocks and hip area, and that is shown there in the way left picture. Type 2 extends down to the knees, so it now includes the thighs, buttocks, hips, and thighs. Type 3 is the most common type. This extends all the way down to the ankles. So we're now including buttocks, hips, thighs, and calves. For type 4, there's the addition of the arms involved, from wrist up to the shoulder. This could be in combination with any of the other types, but this is generally combined with type 3. So our most common combination is 3 and 4. Type 5 is the calves only. So calves, ankles to knee. Okay, and then just very generally to start kind of looking at stages, if we're going to look at a general picture, the first picture shows no involvement. And then we have stages 1, 2, and 3. So the second picture there is stage 1, where you're starting to see a cuff or a ring around that ankle. The third picture would be stage 2, and this is where we're getting more fibrosis and more nodules. And then that final stage, stage 3, you're seeing some lobules, a much greater progression of the fibrotic edema. And I'm going to kind of list those out there too. That stage 1 generally starts out with a pretty smooth texture. You're just starting to see that cuff. Stage 2 is more of that dimpling. You can now palpate some of those nodules in the skin. And then type 3 is where we're really getting more fibrosis, larger nodules, and some of those lobules with some asymmetries starting. Now, what I do see is at further stages, once we have more edema accumulating, you can start to see a smooth texture again because of that fluid buildup. Okay, so these are some pictures of type 1 lipedema. These are borrowed pictures because in my many years of treating, I have never treated a patient with type 1 lipedema. So to me, this says that we are really underdiagnosing type 1. I think this is largely because of the area, because it is around the buttocks and the hips. And very likely physicians and even therapists are not getting a chance to view this area of the body. We're often looking at ankles. I know physicians are often looking at ankles for edema. Certainly this condition is around. I do think I see it out in the community, but again, have not had a patient diagnosed with type 1 sent to me personally for treatment. So I do think this is a big area where we really need to improve with our diagnoses. Type 2 lipedema. Now this type of lipedema, I did not see it in Omaha, Nebraska, and I worked there for 10 years or nine years. However, I see type 2 lipedema a lot in New Mexico. A lot of patients are Hispanic background from northern New Mexico. I want to point out the picture on the left. You can tell this is not a very involved patient. In fact, I think she probably wouldn't have gotten diagnosed for many, many years if it wasn't for the fact that we were, first of all, treating her mother who had type 2 and was very obvious. And then also she had started some physical therapy in a different clinic in town for knee pain. And as they worked with her tissue, they said, you know, you have swelling in here that we can't explain. And your tissue is bumpy. And one of the therapists said, I think you need to go see the lymphedema therapist at sports medicine. So thankfully, she was sent to us very early. That's a very low stage 1 lipedema. And that's the type 2. On the right hand of the screen, that is more of a stage 2 leading into stage 3. This again, Hispanic background, northern New Mexico. You can see the difference between the calf and the ankle is quite severe compared to the thigh. This is after an awful lot of reduction. She did have a lot of edema present in the thighs. She does have a chronic non-healing wound on that left side as well. And that's why she is wrapped up and bandaged. And then just to continue on with this type 2 that extends only to the knees, includes the buttocks, hips, and thighs. This is definitely stage 3, very fibrotic, very painful, very heavy thighs. And again, here you can see that extreme disproportion between the calves and the thighs. She is now asymmetrical, so she's starting to get the secondary diagnosis of lymphedema as well. You can still see that left side is much larger, really hangs over the side, but you can see there is some swelling starting into the calves and a little bit of ring there at the ankle, but still very little edema in the feet or calves. This particular patient had a lot of knee pain coming in. The doctor said there is nothing you can do, of course, lose weight. She was having difficulty with just walking. She was also having her legs seize up, especially when trying to drive. After 9 visits with us, she lost a liter of fluid that was primarily on the left side. You could see I had other therapists in the clinic saying, wow, she's walking so fast now. And her pain went down to now where she's reporting really no pain, except for sometimes with driving, she'll still catch. We did not do compression with her initially. We were treating only with MLD because things were very painful and very sensitive. We will show you more about treatment in part 2 on Thursday, as well as compression, particularly for difficult shaped patients like that one. So this is a type 3 lipedema. This is our most common type that we see. This is extending from the buttocks, hips, all the way down to the calves, ending at the ankle. This is a a stage 1. You can start to see the cuff at the ankle. The skin is still pretty smooth. However, you can see the dimpling of the skin. There are different terms used to describe that. None of them are very flattering. You'll hear mattress or cottage cheese, cellulite, but you can see that dimpling throughout the thighs and the smoothness more in the calves. She was lucky to get to us early, sent by one of our vascular surgeons who is familiar with lipedema. This is also type 3 lipedema, but now we have progression. The picture on the left is showing, increased size. The cuff on the ankle is even more evident. You can see that the feet are clearly spared. They are still bony, and there's definition of the tendons in that area. But you can definitely see that dimpling progressing. There's less of the smooth, oops, let me go back there, less of that smooth texture that we see in stage 1. Now, this is stage 3 on the right, where we are getting some progression here too with increased edema. So I was talking about that smooth appearance kind of returning at the later stages. You do see this here in this picture. Her calves now are a little asymmetrical. However, there's still that deep cuff at the ankle, which has grown. The feet are still generally spared. There is a little fluid there on the right, but you can see the dimpling throughout the thighs. And certainly that was there in the calves as well, but now has a little more of that fluid accumulation in it. So those are the stages there of that most common type of lipedema, that type 3. All right, this is our type 4. This now has the addition of the arms. There is also a cuff at the wrist, similar to in the legs with our type 3. With type 4 though, this could be in addition to any of the lower extremity types. The hand is spared and remains thin and bony. and not painful. I did include that picture in the middle just because I think it really shows how the arms almost look like they're superimposed onto this patient's trunk. The trunk looks quite small, and then it almost looks like those aren't quite her arms. But that is pretty typical there. I often see the upper arms will be the ones that progress and start to carry more fluid and sometimes get some asymmetries in there, and you can feel that fluid. Okay, type 5 lipedema. So this is another type that I have rarely treated. In fact, I've only had one patient in my career with type 5, which affects only the calves. So I reached out to this patient. I hadn't seen her in about 4 or 5 years, and reached out to her and asked if she'd be willing to share a picture because, you know, it's a unique type that I haven't treated a lot. And, you know, she agreed with gladness because she really wants the education to spread. And, you know, she shared with me how her current physician, in her words, feels that she's making up her condition, that it's really not a real condition, which is really frustrating and sad for her, but she was very happy to help. When she sent me the pictures, I was really shocked to see that this looks more like a type 3 now. When I knew her, the thighs really didn't have any dimpling. They were quite thin comparatively, and the calves were about as large as I see here in this photo. So that just shows me in 4 years, she does live quite a ways away and she hasn't had treatment again, that things have really progressed for her too. However, I think you can still see the difference in the calves and how pronounced that edema, that lipedema tissue really is in the calves. So another one here that is rare and we need better diagnosing for. Okay, so now that we've seen some pictures, let's talk about some specifics that come with the lipedema. With lipedema, it's really the fat cells themselves that are taking on the fluid. It's a little different than lymphedema, where the lymph fluid is more kind of like a river, which makes it a lot easier to treat. We can just move that fluid out with our manual lymphatic drainage. In lipedema, the tissue becomes fibrotic around the outside, the adipose cells, and they start to swell. Initially, there's some microvascular damage. The really small venules start to fail and leak fluid. And as those adipose cells swell from that vascular edema, they start to cause lymphatic overload. So as they get larger, they cause damage to the lymph vessels in the region. So it's now a mechanical damage of now the lymph. So it's this combination of vascular and lymphatic deficiency. With lipedema, the interstitial organ is also enlarged. So there's a slowing down of the movement of that lymph and an overwhelming load because of the damage to both the vascular and the lymphatic system. So as most of us probably know, lipedema is tender. The skin is painful to the touch. I have a lot of patients talk about their children, just trying to read them a book and lean on them, how it causes, you know, significant pain, usually in their legs, as well as their spouse, you know, or their partner, and how frustrating that's been, especially to not know the cause. Because of that tenderness, sadly, a lot of these patients are misdiagnosed with fibromyalgia when that's not really the case. Now, certainly they could have fibromyalgia in addition to lipedema, but more often what I see is that they don't have the fibromyalgia. They really just have the lipedema. And when we start addressing that, we can really make some progress towards their pain and their mobility. Some specific spots that are tender in patients with lipedema, this would be really the type 3, the common type, would be tenderness at the inner knee near the pes anserinus area where the adductor muscles attach there. Also posteriorly behind the knee at the distal hamstring insertion. Often at the distal calves around the ankles, and also often at the inguinal nodes when they're full. So I often check a patient initially. Sometimes in the clinic, another therapist will say, "Can you come look at my patient?" And I can kind of just feel around their pes anserinus region, feel that medial inner knee, as well as the hamstring area, and feel the congestion even through their clothes, and feel the tenderness because I can feel the toxins and the lactic acid that have built up. built up. And, they're often like, how do you know I hurt there? Well, it's pretty easy because every lipedema, or most lipedema patients are tender in those same spots. I think it's a good thing to note. Lipedema is generally genetic, although they don't know the exact gene or where that genetic SNP maybe is happening, although there are a lot of people researching that. There generally is a hormonal component, and this, can cause the symptoms to start during puberty, as well as pregnancy, and I've even heard some cases that, the symptoms really start around menopause. Primarily females, almost all are females. The estimates do vary. Some numbers that I see a lot are 1 in 9, which is about 11% of females, which is a lot. I've seen estimates up to 30%. So this is really a large number of females. At the very least, there are millions in the US. There are some rare cases of this being diagnosed in men. I have never had a male patient with lipedema or met one personally, but there are some rare cases of that. But a hallmark feature is also that cuff or that ring at the ankles. And we saw that in our pictures of the type 3. That was pretty clear. And that's a pretty big hallmark for diagnosis, as well as the tenderness. And just noting that the lipedema does not involve the feet, hands, upper trunk. The head and neck are also spared. And this doesn't mean that they don't have issues with their hands or feet, like orthopedic issues that we'll get into in a little bit here. But the lipedema tissue itself is not found in the feet, hands, or upper trunk. And my feeling there is there must be something unique to the adipose cells that are found in our limbs and our distal trunk compared to those that are found in our head and neck, hands and feet that are not allowing this microvascular damage and lymphatic damage. But I don't believe that has been fully researched or known yet. And even though the feet and hands are spared, a lot of patients do experience cold hands or feet relative to the rest of their body. Lipedema also has a negative Stemmer sign. This does turn positive once there's progression into lipedema with lymphedema. And I will show a picture of that later in the slide here. All right, some further lipedema features. We often have myofascial adhesions. That's because of the fibrosis that's around the adipose cells themselves. And then as we start to get pain and we're decreasing mobility, we get those adhesions all through the fascia as well. Lipedema is known to have easy bruising, although it's not rare for me to have a patient who says, I don't really bruise easily. But for the most part, people do state they do bruise easily, and I see that in the clinic. Again, that smooth balloon-like appearance. We see that with stage 1, and you can also see that here in this stage 3 with the progression. And then lack of hair growth. Most patients with lipedema state that they have never grown hair or their hair stopped growing a long time ago on their legs or their arms that are affected with the lipedema. Of course, they do have hair on their head still and usually in the axillary region, but not on their legs. And this is also common with lymphedema. It's because of the diffusion distance being so great. So the arterioles, and those capillaries, those small blood vessels that bring our nutrients and bring our oxygen to the skin are so far removed from the skin because the swelling is in the way. The toxins are in the way. So that nutrition's not really able to get up to the skin and support the hair follicles for healthy growth. Some other common features of lipedema, we generally see varicosities and hemangiomas. I have an analogy for this I often tell to my patients, but I say it's like every fat cell is wearing a sumo wrestler suit. And they're all packed into a room, all your adipose cells. And then your new veins and your new arteries are really trying to make their way through and spread new routes, and they're getting jammed up because the space is all filled with these swelled up adipose cells. So because of that, we start to see them bind up around each other, come to the surface, and you can see that clearly in this picture here. We also see lipomas very commonly with lipedema. These can be anywhere in the body. I've seen them absolutely everywhere. Some patients have a lot, some patients don't have many. They may be deep to the skin and we can't palpate them. And then the nodules as well. Nodules, that gravel-like texture, it's very dense, it's painful, and that's more due to the fibrotic nature of those adipose cells and how they lay in the tissue. Another common feature that I see with lipedema is lateral stretch marks at the knee. I have never seen this in the literature. It may be out there somewhere, but I myself have not been able to find people writing about the lateral stretch marks. The only reason I really include this is because I see it so often. And as of recent, I've had a couple patients where their physician said, no, those are scars. Those couldn't be stretch marks. You don't get stretch marks at your knee. Well, if your knee is growing at a disproportionate, rate, and it's full of edema and toxins and fibrosis, you do get stretch marks. So you can see I've got a couple pictures here where the stretch marks are right at the knee or the patella, but also in that inner thigh region. And every time I see them, they're lateral. They're not going vertical. They're horizontal if the patient was standing. Another main feature of lipedema that we see very commonly is hypermobility. So this here is a knee. This is a type 3 patient. She has quite severe hypermobility there of her knees with the hyperextension. This is because it's a connective tissue disorder. Thankfully, she is very young and does not have any trouble at this time with arthritis, osteoarthritis, or in need of a joint replacement. A lot of the patients that we get who are older, in their 50s or 60s or 70s, have had arthritis in their knees for many years because of that hypermobility or loose joint function. So it's causing wear and tear. And then they need to get their knees replaced, sometimes their hips replaced. Unfortunately for these patients, after a joint replacement, they do not process that normal swelling like most patients would. And so they really struggle with those joint replacements and often see a worsening of their lipedema after the surgery. Very often that's when we're seeing the patients come in for the first time, because now their physician is also wondering, why isn't their edema going down like most of my patients? So they'll end up into our clinic that way. Because of that hypermobility, I'll often hear patients describe chronic ankle sprains that they've had throughout their lives, or lumbar pain, also related to that hypermobility. All right, another common lipedema feature is pes planus. This is known commonly as flat foot or overpronation. They often have a tight plantar fascia and really benefit from arch supports. They can also benefit from soft tissue mobilization to the plantar fascia. I grab a quick drink here. And then also genu valgum. So this is commonly known as the knock kneed. You can see that again here in the photo. Generally with this comes also a tight IT band with tenderness, of course, usually weak in the VMO muscle. Almost always have tenderness at the pes anserinus, again, just medial and distal to the knee. With that, sometimes it does progress to where there's actually a large visible amount of swelling in that pes area, and it can even lead to the pes anserinus bursitis, so we will treat that separately. And then we also see that lateral tracking patella. And Jeanette, did you want me to answer questions as we go or save them for the end?
It's whatever you prefer, Deana.
Okay. I do see that someone was raising their hand, so let's see if I can get this. Excuse me. So do we know why the feet and hands are spared? That's a common question from my patients. I did mention that a little bit ago. I have not seen where anyone knows definitively why they are spared, but my belief is that, as I mentioned, that there's some different makeup of the adipose cells themselves in the hands and feet versus, the limbs and the trunk. That's just a guess of mine. I don't know, but my thought is the vascular system and the lymphatic system don't change that we know of as those vessels pass from the fingers up the arm or the feet up the calves. Okay. And how is lipedema diagnosed? We'll get into that a little bit later, actually. So I'm going to go ahead and skip that. Okay. And then can you explain more about the interstitial organs that are enlarged? So this is more just from a backup of the lymphatic fluid, as it's not processing as fast as it should be in a healthy system because of that mechanical damage that we're seeing. First that microvascular damage, then we're seeing that lymphatic damage. So it's backed up, causing, just like your inguinal nodes might become enlarged as they're taking on a greater load. Okay, and yes, definitely lipedema can progress. So another question was, can lymphedema turn into lipedema? No, it's only the other way around. So lipedema can progress to lymphedema, but it doesn't progress the other way. Lipedema is independent. It's genetic, runs in females. So it doesn't go that direction. And then another question is to talk about the combination of lipedema and lymphedema, and I will do that also later in the lecture. So I'm going to go ahead and move on here. The genu valgum, very obvious there, and that does need to be treated as you would with any orthopedic patient in the same manner. All right, some more challenges that come with lipedema. Whoops, I'm not moving too fast there. Body shaming. That's one of the biggest one I see in my patients with lipedema. Sadly, it comes from providers, our own family, our friends. I often hear mothers who have kind of guilt or shamed, their daughters, not understanding why they can't be more fit or look more like their friends. Providers also who are really pressuring patients to lose weight and they're not able to do it in the traditional ways with diet and exercise, regardless of how well they eat and how much they exercise, their legs or their arms do not change. Along with that, of course, comes self-shame. So there's a lot of self-guilt and shame that people will put on themselves, wondering, why am I different? Why do my legs hurt to touch? Why do I exercise 5 times a week and eat so healthy and I can't change this shape? Whereas I see my friends who are able to do that. So of course, with all of that, we're going to have some mental health issues, depression, anxiety. I would say 95% of the patients that I've diagnosed or started to talk to about lipedema and given them information on lipedema cry in my office. It's such an emotional response, and they're just relieved to know that there's a name of something that can be done, and that it wasn't all in their head, and that they weren't hypersensitive to touch. They weren't making this pain up. They weren't making any of this up. So it's really, you really have to be gentle and listen and just be supportive. And the one thing I tell my patients is, look, it's never going to get worse now, because now you're going to know the tools. Now you're going to know what to do, and we're going to start improving from here. So body dysmorphia, I definitely seen that. Even after there's been some reduction with treatment, patients still will view themselves as larger than they really are. So that definitely requires some specialized treatment with psychology, but you will see that. Eating disorders, very common as well. You'll find patients with anorexia nervosa that have, decided that they just must have to starve themselves, and it really still doesn't help. You also see some bulimia. There are articles noting as high as 74% of patients with lipedema also have anorexia, despite the size of their legs or arms. Exercise habits, I also see the extremes here. I certainly see patients that are kind of workoutaholics that have they live and breathe working out and running, and probably not helpful, especially the running. But then I also see those that are now so immobilized and have so much pain that they're not able to exercise. And then diet as well too. I just see all spectrums there. Those who are like, I'm not eating a single carb, no sugar, no gluten, only fresh fruits and vegetables. And then I see those who say, well, it doesn't seem to matter, so I'm just going to go ahead and eat whatever I want. Okay. Some challenges with lipedema. I have seen some worsening here with COVID-19. I have one patient who started to notice some lipedema around menopause, but then had COVID and was quite ill for a few weeks, and states that her symptoms really worsened after that. And that's what made her seek out care. I have a much younger patient who also saw a lot of worsening with her lipedema after having COVID-19 again for a couple of weeks. So we are seeing that very likely because of the immune response. The lymphatic system is overly busy trying to fight the virus. Other lipedema challenges that come up are clothing. Women have to buy shirts that are too large for them really in order to fit the arms. So a lot of women buy batwing style shirts with the large opening in the arms or in the sleeves. Pants are very difficult to fit. In order to fit the thighs and the calves, they often have to be too big at the waist. So you're seeing patients really cinch up at the waist. A lot of my patients will wear wide-legged pants because that will accommodate the thighs. They often don't want to wear capris or shorts as it shows off the ankles. And then skinny jeans. I hear that a lot, that, oh, I can't wear skinny jeans because my calves don't fit. No matter how large my size is, it doesn't equal, the ratio of thigh to calf. So I have a lot of patients who wear dresses or skirts because they're not form-fitting and they kind of hide the legs, as well as they don't have to worry about the tenderness as much as with something that's tight-fitting. And then boots are challenging. I often have patients too where they're not able to pull boots onto their calves and zip up boots. And, all this is a cosmetic issue. A lot of us as females, this is part of our individualism and our expression. We like to dress up and wear cute things and things that are in style. So it really is, an emotional challenge as well in that way. Okay, so I just have a couple pictures here of clothing and then I'll look at those questions again. The patient on the left, you can just see that these are very wide leg pants and they're still tight and pulling throughout her thigh region. Yet her belt is loose, her waist is very thin. Same thing on the right here. Again, we're very fitting throughout the calf and the thigh region, but she could go about 4 sizes smaller in the waist. Okay. I do wish that there were more options for patients with lipedema, but at this point, it really leads to custom clothing, really. Okay, so let me just take a look here.
Deana, I can totally ask the questions for you and you don't have to worry about reading them and navigating, and you can just answer.
Sure.
Okay, so Robin asked, does anyone else besides her have their brain to protect them when they look in the mirror and lie to her about how big she really is?
Oh, that's interesting. I mean, I'm not sure on that one. It might be another just type of body dysmorphia, or you might be being too hard on yourself and you really are seeing reality and it's not as bad as you think. Yeah, that one, I don't think I have the full training on the psychology level to answer that one any further. But yeah, certainly reach out to some support groups and Facebook groups and see if anyone else has had that experience.
Thank you. Robin also asked, is there anybody else who is sick of providers yelling at them and telling them that their pain is outsized for the damage that they are seeing?
Certainly. I think that's very common. And that's why we're here, is to really kind of spread the word and try to get more providers educated on how to diagnose and treat this condition. Because certainly if a patient's lucky enough to get a doctor to really look at it and understand it, there's still some misunderstanding about it, I guess, and some shaming.
Thank you. Claudia asked this next question, but she wrote cellulitis, but I do think she probably meant cellulite. So I'm going to interject that. But her question is, how can a person tell the difference between cellulite, which gives the appearance of lumpy legs, and that which may be lipedema?
Sure. That can be hard to tell, and they do kind of overlap. But that will take us right into our next section, and I hopefully have a better idea of that after going through a differential diagnosis. So I'm going to go ahead.
Yeah,
forward.
Sounds like good.
Oh, was there another one?
Oh, no, that's the perfect segue for you to go back to your presentation.
Okay, excellent. Okay, so we're going to look at differential diagnosis. I think the most important to look at is lipedema versus obesity. Most of us who have some training in lymphedema have seen, really closely what lymphedema looks like. But it's really that question of, this looks like adipose tissue and feels like adipose tissue. How do I know it's not obesity? This was the same question that I had when I first started treating lipedema many years ago back with my mentor. And it's taken me, a few years to really see the difference, and then to really be able to explain and show and really mentor others on seeing that difference. So I hope this helps. But with lipedema, we've seen we have the thick ankles. We know the upper trunk is spared. We know that the adipose tissue is disproportionate, right? This can progress to lymphedema when there's enough damage, and we'll talk about that a little later. Lipedema, of course, primarily female, the little improvement with diet and exercise. And it does improve with our complete decongestive therapy, our manual lymphatic drainage and compression, as well as exercise and education. For diagnosing lipedema, we rely partly on their subjective history. Does this run in your family? When did it start? Did it start around puberty? Have you ever had your feet affected? Or have your feet always been small? Are you painful to the touch? All of those pieces kind of help us with our diagnosis. And then palpation, feeling those key areas I mentioned, over the pes anserinus, the medial inner knees, the hamstring insertions, feeling for tenderness in the calves around the tibia. All of those are going to help us with that lipedema diagnosis, as well as all the other signs and symptoms we talked about with hypermobility, genu valgum, pes planus. Those are not exclusive to lipedema, but all combined with that cuff at the ankle can help us lead to that lipedema diagnosis. Okay, then we look at obesity. When we're looking at obesity, we are looking at a very normal fat distribution. We see thin ankles with their malleoli visible and palpable, their ankle bones, with a nice shape to their legs. We're not seeing that dimply tissue in the lower extremities. Usually it is the trunk and the abdomen that are really pronounced with obesity. Now, sometimes that can lead to lymphedema also because of the pannus. The large pannus can put so much weight on the inguinal lymph nodes that it can actually damage them over time. So that can lead to lymphedema. Obesity also is common in both males and females, I would say equally. And this does improve with diet and exercise. So there are changes, and it's, easy to lose weight if you're doing a proper diet and a proper exercise program. And then, of course, CDT has no effect. So our complete decongestive therapy is not going to improve obesity, or all of us therapists would be very wealthy, but that does not work. So those are kind of the biggest differences between them. And I really think the ankle portion is something to take good note of. So here I have a picture on the left of that type 3 lipedema, and on the right is a patient with obesity. So there's a very clear difference between the shape of the legs. Now, the patient with obesity likely has some cellulite up around her hips and around her abdomen. It is very different from the nodules and the gravel-like texture you're seeing in lipedema. Cellulite in someone with just obesity, it's going to look more drawn in, more tethered down in a way too, almost a deeper, wider dimpling. Whereas in lipedema, it's this more mattress appearance. It's kind of throughout, and it's a little more superficial. So I think that's a very good picture there to look at. Okay, so then lipedema to lymphedema. Well, we've talked about lipedema a lot, so I'm not going to repeat all of that. But it is symmetrical. It's both sides, unless it progresses on. This does not improve with elevation. In fact, some people have worsening pain with elevation. And it has that hereditary component, also that negative stemmer sign. And CDT is helpful, compression and manual lymphatic drainage. Lymphedema is going to involve the feet. It's going to be pronounced distally. Patients usually have that dorsal hump on the top of their foot. Because of the way the anatomy of the lymphatic system is, that we're broken into 4 quadrants plus the head and neck, lymphedema is usually going to be asymmetrical. going to be one quadrant, or if multiple quadrants, they won't be equal because it won't be the exact same degree of damage to all the quadrants at the same time. Lymphedema does not improve a lot with elevation, but can still be helpful. Usually there's a history of that lymph node removal. If it's primary, someone who was born with it or it was genetic or an anomaly of the lymphatic system, you're usually going to see some early signs, and again, it will be asymmetrical. They are going to have a positive stemmer sign, generally not painful. And then lymphedema is more known to present with hyperpigmentation, darkening of the skin, the hyperkeratosis, there's extra skin cells, papillomatosis, that looks kind of like warts on the skin from weak areas, and then lymphorrhea, which is weeping of the lymphatic fluid. You also see the peau d'orange, which looks kind of like an orange peel in those later stages of lymphedema. And then again, the complete decongestive therapy is helpful, and that's how we treat it. So I'll just show a comparison picture here. Again, we've got lipedema, which is symmetrical. You see the cuff, you see the dimpling, compared to lymphedema, which now has the dorsal hump on the feet, as well as asymmetries. One leg is larger than the other, and those lobules. The stemmer sign, generally this is taken more right at the base of the toes. For picture's sake here, we wanted to really show that thick fold on lymphedema. That is a positive stemmer sign when you cannot get a thin layer of skin between your fingers, whereas in lipedema, it's going to be negative. You can fold that skin. I often do this sign throughout the body. I'll do it in the upper arms to see, is this fat, is this adipose, or is there edema in there and I have that thick fold of skin? I find it to be helpful to just test other areas. In the interest of time here, I'm going to try to go fairly fast through the rest of these. Our vascular conditions, chronic venous insufficiency, those are related to valve leakage. So those do improve with elevation. As you elevate, the edema can run back towards the heart. This is generally symmetrical, does involve the feet. You do have some pain. And here MLD can be helpful, but compression is really helpful as well. Systemic edema, this is heart failure, kidney failure. Usually this will improve with elevation. You're gonna have swelling pronounced proximally. Often it can also be distally, depending on the progression. Usually it is on the dorsal hump as well. And with systemic swelling, I see a lot of pitting. Usually pretty symmetrical here too. And compression can still be helpful. It can stop the weeping or the lymphorrhea and just keep that mobility of the ankles by keeping some swelling out of there. But generally, MLD is contraindicated. We are moving the fluid to the superior vena cava with manual lymphatic drainage. So we can overwhelm, especially in congestive heart failure, we can overwhelm the heart and cause more shortness of breath and generally feeling ill. Diuretics are commonly used for systemic edema. So this is a picture here on the left of the screen is a phlebolymphedema. So this is a vascular lymphedema progressed into lymphedema. And this is a gentleman here. You see asymmetries. You do see the staining of the skin. He does get some lymphorrhea as well as some wounds. And then that systemic edema. We are seeing it on the top of the foot again. You're seeing pitting. He took his compression garments off, but shows much more pitting than you would see in lipedema and often in lymphedema as well. Just briefly to talk about blood clots, deep venous thrombosis. This is going to be quick. It's going to be painful, usually pain, redness, warmth. You're going to see swelling distal to the site of the clot. Asymmetrical. It'd be really rare to get a blood clot in the same place on both legs at the same time or both arms. So usually asymmetrical. They usually do recommend elevation and compression, but not manual lymphatic drainage because we don't want to dislodge that clot. And anticoagulants, of course, are important there. And then there's arterial. So this is a decreased pedal pulse. This is the arteries are having trouble getting down to the limbs and feeding them. So it is painful, usually symmetrical again. Patients often have weakness, wounds, the hyperpigmentation of the skin. And on this one, we do not want to do compression or manual lymphatic drainage. Those are both contraindicated. So manual lymphatic drainage contraindicated in DVTs and arterial conditions. Compression also contraindicated in arterial conditions. Malignant lymphedema. This is where we see mechanical blockage, usually from a tumor or a lesion blocking that part of the lymphatic system. Elevation really doesn't help. It's usually asymmetrical. Here we're going to see the swelling usually more proximally near that part of the quadrant than distally at the hands or feet. This is usually painful, and generally CDT is contraindicated here unless the patient is receiving chemo or radiation. Then we may start with some CDT, or if the patient really just wants palliative care. And then we have dependent edema. This could be symmetrical or asymmetrical. With conditions like Parkinson's, you can see symmetry. A CVA is usually going to be asymmetrical. This usually does improve with elevation. There is pitting. Again, we've got it pronounced distally. Usually some pain or aching, and this is due to lack of muscle pump from paralysis or severe weakness. So in these cases, compression is helpful. I've also found manual lymphatic drainage to be helpful as well. All right, so we're getting close to the end here. We've got some referral sources. Sadly, primary care, healthcare providers are not usually our biggest source of referrals. I get more from vascular. I have a vascular surgeon in Albuquerque nearby that is certified in lymphedema. We've got a good one here in Santa Fe as well. I get a lot of patients more from wound care, but really from other PTs and OTs who have learned what lymphedema looks like. And also massage therapists. We have quite a few that are certified lymphedema therapists in town who now have an eye for it and are sending patients. Patients often are coming also from friends or family who have been treated in the past. But honestly, I'm seeing more and more self-referrals. Patients are doing the research. They're going on Facebook, they're going on support groups, and they're finding out for themselves what's wrong with my legs and or my arms. And then they're going to the doctor and trying to educate their physician on their condition to get a referral to come in. I'm still a little shocked when my referral says lipedema though, and not lymphedema. I was like, oh wow, this is a great doctor. Recommendations for referrals out, whatever is needed. If it's vascular wound care, mental health very often, nutritional support or a nutritionist, support groups. We don't have a physical one here in the Santa Fe area right now, but there are a lot of online support groups that I would recommend any patients get involved with. And then treatment-based recommendations, which we'll talk about much more in part 2 on Thursday regarding compression, pumps, and orthotics. So our key points today were looking at the different types. There's 5 types. Looking at the 3 stages or progression. Going through all the features and challenges of lipedema. Going through some differential diagnosis. And then talking just briefly about our referral sources and our referral recommendations. And I just want to take a minute myself to really thank the National Lymphatic Network. You're an amazing resource. We give every single patient handouts from the National Lymphatic Network. We always want to give them the risk reductions, and we consider you the last word in any advice for patients with lymphatic conditions. So I really appreciate all you guys do. Thank you for sponsoring this. And also Eleanor and Lindsay for all your help putting together this webinar and just the relationship I've had with Eleanor over the years. You have excellent products. I appreciate all you do for our patients as well. Be sure everyone to tune in on Thursday when I do the second part, which is treatment and intervention. And that's the part that I really feel is where I have something to offer to really help with some of the treatment that we're not taught in school. So I hope you all can join us. Thank you.
Thank you so much, Deana, for a wonderful presentation. I've definitely seen some other presentations on lipedema, and it's always interesting to see it repackaged in a different way based on another expert's perspective. So we really appreciate your talk very much. Thank you.
Thank you, Jeanette.
So we have a couple of participants who have raised their hands, and so I'm going to see if they would like to actually speak their questions. We have Marie Josie and also Maria. So I'm going to allow them to talk, but while they're kind of getting acclimated, I'm going to take a few seconds to just correct my mispronunciation of cellulite. I am 25% French, and it's just the French coming out in me out of me when I said cellulite. So that's just the explanation. I know it's cellulite. So anyhow, so Marie Josie, would you like to talk? And if not, then Maria, would you like to talk? And we have one more. Katie is also raising her hand, and so we're going to give her the opportunity. And otherwise, we'll move on to the questions that were typed.
Hi. So I am a pelvic floor therapist also. And like literally right before this started, I had a patient where I'm pretty sure now that she's got stage 1 lipedema. And I was kind of talking to her about it. But do you see pelvic congestion syndrome along with lipedema or like comorbid pelvic pain, hemorrhoids, kind of like varicosities that's really just more in the pelvis? I've seen 2 or 3 of them now where it's just kind of becoming a little bit more of a trend.
You know, that's a great thing to point out. I'm certain there's a higher level of hemorrhoids, pelvic congestion. I don't know that that's in the literature either, but it would definitely make sense because even in a type 1, a type 2, or a type 3, that area is involved. So that tissue is not going to be spared. You know, it's going to have the same symptoms and signs as the rest of the tissue, including the varicosities, the hemangiomas, the tenderness. So yeah, absolutely. I think there's a big connection. I work here with a pelvic floor specialist, and I'll have to pick her brain about this as well, because we think there is a lot of overlap. And now as far as incontinence and those type of things, I don't know if those are related, but very likely it happen in combination.
Thank you so much, Deana, and thank you, Katie, for your question. We also have Robin, who we've heard from before, and we're going to give her the opportunity to speak.
Hi, I was the one that asked about the dual condition, and if you could talk really quick about that. And second of all, the second session, which I really want to attend, I have a prior commitment. Is there a way to record this session? And what about getting printouts of your screen grabs that you sent?
Yes, they are absolutely going to record the sessions, and I believe we'll send a link out after. So if you aren't able to attend, you can watch the link.
Okay.
After that. I'm not sure about sharing the slides, if they're going to do that or not. Lindsay or Jeanette, if you have any input on that, I'm happy to share them.
Well, actually, Deana, that's totally dependent upon you.
Okay.
You know, my experience is that most faculty or most speakers don't like to files out because it's easily recreated and reclaimed. And
Yeah.
so, but in video form, obviously, you're the one who's giving the presentation, so it's all you. So it's all up to you. You let us know.
All right. Well, thank you. Well, I think the video link will be shared. And thinking about, you know, how many pictures I have in there of patients, I might not share those slides. But we certainly will send the email link out so that people can watch the video on Thursday.
Okay.
And then the other question was about the progression from lipedema to lymphedema. Is that correct?
Oh shoot, I'm muted again. Sorry. I can't.
We actually hear you just fine.
Oh, you can hear me. Okay. No, my physical therapist says that I have a rare dual condition that she's calling lipolipedema. And
Yeah.
she says that in addition to the having, you know, I'm losing my words, having the wildly out of proportion like hips and thighs and somewhat calves, that I also have the fibrous fat, but it's also striated. So I'll have places of really thick, and then right next to it will be almost no fat at all. So if you went across my legs and touched, it would be nothing, nothing. Oh my God, the pain. Nothing, nothing. Oh my God, the pain.
Okay. So yeah, that part is a little unique from what I've seen in the clinic. But lymphedema is very common. That is the progression of lipedema to lymphedema. And I've been kind of going with Dr. Karen Herbst's recommendations that we actually diagnose them separately now. So instead of saying maybe a type 3 stage 2 lymphedema, we are diagnosing the lipedema separately, a type 3 stage 2 with lymphedema stage 1 or 2. But that progression is very common. Yeah, as those, you know, as the mechanical damage to the lymphatic system progresses, there's more and more fluid intake, a lack of ability for that lymphatic system to keep up with that load. And so slowly we'll progress to where we now have involvement of the feet, asymmetries, all of those things. The striated, I can't really speak to, other than I can say nodules, lipomas, all of that. The distribution does change in a lot of the patients that I treat. A lot of the type 2 really have that on the outer parts of their thighs. More patients have it on the inner. So it can vary, certainly.
Thank you so much, Robin, for your questions. Thank you, Deana. And then we have one more person raising their hand, and that is, excuse me, forgive me. It is Laura Molnar.
Yes, good evening from Western Slope of Colorado. So close by. Hopefully I can come by to one of your sessions down in New Mexico soon. I am actually a physical therapist working in a joint replacement center, and also been a LANA certified CLT as well. So I'm bringing that lymphatic vision much more to orthopedic recovery. And I'm very much looking forward to Thursday's presentation, but I was wondering if there was any specific research that you've seen on lipedema, orthopedic surgery, and potentially proper compression garments following, if that's more of a question for Thursday, I understand, compression garments following particularly joint replacement surgery, just because we have doctors right now who are obsessed with TED hose, and God forbid that they use just a good old compression sock. But so that's my goal. I just moved here, so that's my goal for the year, to work with these doctors. But if there is any research that would suggest that other type of compression garments after orthopedic surgery would be good.
Yeah, I mean, absolutely, I agree with you. TED hose is a very old school idea. It doesn't really do a lot, tends to bind, fall down. We all know that treating therapists here that a class 1 or even a 15 to 20 grade compression garment is going to do a lot better. It's going to improve the healing, get their motion back faster, bring down that swelling. I don't know of any right offhand that I could tell you this is specifically related to orthopedic surgeries or joint replacements. I can certainly look into it. I did write your name down. I mean, I believe it to be true, and I know there's research that points that way, just in general. So let's see if I can find something.
So Deana, we have a lot of more questions in our queue, and on our end, we're okay to just continue to record because it's such valuable information for the community. We want to be mindful of your time. So how much more time can we take of yours?
Why don't we do another 15 minutes or so, if that's okay?
Sounds great. Okay. So we also have Trisha, who would like to ask a question. And so Trisha, the stage is yours.
Hey guys, thank you for taking my question. I was wondering about the coding, outpatient billing for lymphedema. Do you code the lipedema as I-89?
We have just started using the actual ICD-10 for lipedema. And, I can't even tell you what that number is now. It comes up in our computer system right away. Prior to that, we were coding everything as either generalized edema or lymphedema. A lot of the patients that we get are having some part of foot swelling starting because they're getting to us too late, honestly. So in those cases, we can use that lymphedema code too, because there is at least some component of the lymphedema, even if it's a stage 1 lymphedema on top of the lipedema. But we do have the lipedema diagnosis code now.
Great, that is my question. Thank you so much.
Yes, you're welcome. Thank you.
Thank you.
Okay, Deana, let's go from the top. So you kind of answered it in your presentation, but do you want to just comment briefly again, how is lipedema diagnosed?
Sure. I think a big part is that subjective history. When did it start? Does it run in your family? Is it painful? Has it ever affected your feet? And, I always kind of start pulling information out of them. Like, so have you always had big legs? You're telling me how big your legs are. How long has that gone on? I don't know, since high school. Do you have any family members, any sisters, aunts, mothers? Just trying to pull that out of it. How long have you had tenderness in your legs? So kind of looking at all that, as well as that cuff at the ankle. looking for the varicosities or spider veins or hemangiomas, feeling the skin to feel for the nodules, feeling those common places that are tender. Also looking at those orthopedic conditions with the hypermobility. The, layman's terms are the knocked knees, the flat foot, the hyperextending knee. Kind of combining all of those pieces with your hands-on skills, your palpation, to see if all the pieces fit, and visually, of course.
Thank you. If you don't mind, I'm going to take the next question, which is, why is it so difficult to find compression garments for the thighs that are large enough? Well, compression garments, in my opinion, is an art. The therapist, who prescribes it to you, there's a whole decision-making process that goes into it. There's a lot to consider, everything from your physical presentation to your social your social history. So it's really an art, and it's actually quite difficult, I think, unless you have a method to prescribe compression garments. So really hard to answer that question, other than, it's an art. So the next question is, well, it's actually more of a comment, and we'll see if you'd like to comment on this. Kim said that she was told that massage does not help.
Well, massage is different than manual lymphatic drainage. So, as we'll see on Thursday, definitely manual lymphatic drainage is essential to moving the edema buildup that can be both venous and lymphatic. That's proven that manual lymphatic drainage moves that fluid out. And then we do combine some specialized deep techniques to work on the fibrosis, the tenderness, the increased tone. So most definitely you can see improvements with that. So I would recommend that you go try finding someone who does manual lymphatic drainage, especially if you can find someone certified. And, if you have lipedema, give it a try and see if it helps.
Thank you. Zoltan asked, do you feel as though you're diagnosing lipedema more than your referring physicians do?
Absolutely. And I have to be careful there because we really aren't doing the diagnosing. It's the doctors who want to put in that official diagnosis. But what we are doing is labeling their edema correctly in our assessment. So, they write whatever they write on the referral, and then I write my PT diagnosis, my therapy diagnosis. So that's where I'm being real specific. I'm saying bilateral, upper extremity and lower extremity, type 3, and for lipedema, stage 2, with stage 1 lymphedema, left lower extremity with involvement of the foot. And I might say primary genetic, present since puberty. And I often go so far as to list every possible sign and symptom that I see in a patient, often just to educate the provider and help them know that, oh, okay, she knows what she's talking about. You can look it up. Oh, the cuff at the ankle, the varicosities, hypermobility, bruises easily, family history, palpating, all the pes planus, all of those things I will literally type up into my assessment if they're present, of course.
Thank you so much, Deana. We have 8 more minutes with you. Lisa asked, I have a patient that presents with stage 3 lipedema, and her lower legs are quite cyanotic. I've heard from Dr. Herbst's webinars that this could be a presentation. Do you see this? Limbs are cold.
Yes, absolutely, especially with the progression. Again, as I talked about the adipose cells, almost like they're all wearing sumo wrestling suits. It's just hard to get good circulation through those enlarged cells. So, I think it starts out more hands and feet are cold. And then as time goes on, it can, with the progression, it can be the entire limb. And then actually, as I've treated some patients, they start to tell me, gosh, now I'm like hot sometimes. I used to be cold all the time. Well, it's because their circulation is improved.
Thank you. Diana asked, we encounter DVT in 8 to 10% of patients with lymphedema. When do you recommend MLD in such patients?
I usually rely on the doctor for that guidance. I'm going to start gentle. If it's chronic or superficial, often a physician will clear them for MLD right away. But I really let the doctor do that because they're the ones taking the ultrasound. They're seeing how deep it is, how severe it is. They know how well the anticoagulants have worked. Sometimes, they'll let us go at 3 months. Sometimes it's 6. I have a patient right now who it's 3 months and he's waiting, and another 3 months and another 3 months because it's just not resolving. So I think that's.
Thank you. Jennifer Williams, our continuing education manager, asked, are there any questionnaires or outcomes that you give to patients that focus on lipedema versus lymphedema?
I'm sorry, any outcomes or what was the other part?
Are there any questionnaires / outcome measures, I guess, that you give to patients that focus on lipedema?
That's a great idea. No, we give our patients all the LLIS, the Lymphedema Life Impact Scale. So that's our functional tool that we use. And, you know, it's really based more towards lymphedema. There are some questions that say, compared to my affected limb, you know, compared to my unaffected limb, how tight is my skin? So what I ask patients to do is think of it as before you had this condition. How tight is your skin now? How heavy are your limbs now? How much pain do you have now compared to when you weren't affected? I also tell them to skip any questions that don't apply to them, as that tool will calculate a score based on the amount of questions answered. So that's what we use for outcome measures. But, you know, it'd be great to have a better one developed specifically for lipedema.
Thank you so much, Deana. We're winding down to just a couple of logistical things. One question is, if we can't get the presentation, can we at least get the list of online support groups?
That's a good question too. I don't have a list myself. I just know a lot of patients just, you know, it's lipedema.org and, oh, there's a few of them. I could probably get a list together. Yes, I'll say yes to that one. It might be after Thursday though.
Thank you. A question for me is, was this webinar CEU-able? And unfortunately, no, this is a webinar that is a service to the community, so we're not going to manage the CEU portion of this. The members only webinars that we provide every month are CEU-able, but this is not one of them. And then Joanna had asked, she's just curious how many attendees there were for this evening's webinar. And I'm happy to share that at our peak, we had 249 people on this webinar. So with that, we'd like to say thank you to Deana for an excellent presentation. We'd like to thank LNR USA and Lindsay Ryback. Lindsay, why don't you come on just so we can say thank you to you and see you. Thank you so much for your support of the National Lymphedema Network. Thank you for sponsoring this evening's webinar. And we'd like to thank each and every single one of you for staying on this entire time and actually listening to what we have to offer. We believe that all the educational things that we put out of value, and we'd like to thank you for your time and attention. So with that, we hope to see you Thursday. For all of our conference attendees who are on the call still, we hope to see you tomorrow at the breast webinar, which is a pre-conference mandatory webinar. And I think that's a wrap. Pun intended. Okay. Bye, everyone.